using a fixed drug combination of metoprolol and telmisartan in people with hypertension with ischemic heart disease by using a ambulatory blood pressure monitoring. It's a phase 4 trial, prospective multi-center trial that was conducted in Indian populations by Indian drug. So hypertension at a glance, we know that hypertension is the largest disease, chronic disease across the globe. Nearly 1.3 billion people are being affected. In India, nearly 21% of females and 24% of adults suffer from elevated BP. And hypertension is leading cause for stroke by 57% and acute coronary syndrome by 24%. The ambulatory BP monitoring is one of what we use CGMS for diabetes, revitalized the treatment strategy and protocols by using this tool for day-to-day assessments. So ambulatory BP monitoring is very effective in evaluating the hypertension in patients with significant variations. When there is a significant variations between the home monitoring of BP and in-clinic BP, so ambulatory BP monitoring becomes a standard tool to assess the exact picture where the patient is. And also it can be used to set the target for the individuals and also therapy based upon his BP surge and downs. So accuracy of BABPM is very good. It predicts the cardiovascular events much more far. It correlates much more with the CV events in the individuals, and also identify the masked hypertensions, white coat hypertensions, and dippers and non-dippers, which is very vital in diabetic individuals, because diabetic individuals are non-dippers. They are at risk of developing CV events, maybe vascular at level of the renal or at the level of the brain and heart, so on. Also guides the therapies, which drug shoots for these patients and what the drug, what the dosage can be extrapolated by assessing the ABPM tool. And fixed drug combination, any chronic ailments recurrence, fixed drug combinations. The drugs should be very complementary in actions and synergistic in actions without any inducing side effects. So any fixed drug combinations, if you put together, they reduces the pill burden and reduces the dosing frequency, also improve the compliance, which is very, very vital when you treat chronic ailments. So metoprolol works at the level of beta blocker as a cardiac selective beta 1 blocker, and telmisartan works at the AT1 receptor, which is having synergistic combinations without any adding adverse events. By combination for the drug, what we used in this trial was metoprolol here. How it differs from the other competitive brands, it have a unique patented wrapped matrix technology that makes the deliver the two drugs at a different angles, that makes the control and consistent release. You can see this is the picture of the metoprolol. So the pink color, it is encoded by a partially permeable polymer coating. The pink color is an telmisartan, which is incorporated in explodable polymer. So it releases immediately into the bloodstream. And next is the metoprolol was incorporated in a controlling polymer. So that stands for its 24 hours profile of the molecules. Let us focus on the study what was conducted in Indian subset of population. This is a control study, was a phase 4 trial, open label, multicentric, non-comparative treat to assess the efficacy as well as tolerability of this molecule in patients with angina, stable coronary artery disease and hypertensions. So 88 patients were enrolled in the studies. A number of sites incorporated in India was 7. The study period of 10 weeks, of which screening period 2 weeks and treatment period is 8 weeks. The primary objective is to assess the efficacy of the molecule, and the secondary objective is to assess the tolerability of the molecule in patients with the hypertension ischemic heart disease. The molecule used in this study is metoprolol 25 mg as well as 50 mg. The initiation of the molecule as on the discretion of the physician, based upon his BP, based upon his pulse rate, this molecule was started. So the study design is the first visit was screening period that was allotted for 2 weeks, and the next visit there's a day 1 for the initiation of the molecules. The second visit, the patient was started on metoprolol 25 or 50 depending upon the patient's pharmacodynamic profile, and next visit was followed by 14 to 28 weeks, where they will assess what is the side effect happening because of the drugs, whether the drugs needs much more titration, or when you want a rescue therapy to push the BP control to less than 130/780 as per the ESC guidelines. And the fourth is the early termination or end of the treatment or the study results. The inclusion criteria is any adult, female or male, willing to give consent for the participation, hypertension with established CAD, stable CAD, and BP should be in the higher range of more than 130, 140 for a systolic and 90 for a diastolic BP, with either you do it the clinical or ambulatory BP monitoring. And patients already taking these molecules can be incorporated if they are willing to participate in the studies. Exclusion, all the renal impairment, other hepatic impairment, patient in metabolic acidosis, thromboembolic episodes were excluded. And this is the primary endpoint. The primary endpoint to check the mean 24-hour ambulatory BP monitoring, both systolic and diastolic is taken into consideration from the baseline to 8 weeks. The second endpoint is responders time, how much amount of people are responding to the target therapy of target of less than 130/80, and subdivision is what happens last 6 hours of therapy, because you're going to give the medication in the morning, what happens the last 6 hours to assess the shoulder effect of the molecules, and also they compared what happens first 6 hours and last 6 hours, any peak or trough effect is there. So last 6 hours were incorporated, and people with the first 6 hours and last 6 hours BP difference was computed for these patients. The efficacy aspect, the short-term variability assessed with so much of parameters which you are going to deal, it may be your more statistical significance. The short-term variability, long-term variability of these molecules in terms of BP control. This will be told in a nutshell. Now, last, in addition to that, what happens, the BP happens when you increase the dose from 25 to 50 mg, and what will mean 24 hours BP with people taking high dose when the start of the drug itself, and what happens for the escalation of the molecules. So, determination of sample size, many of you may ask why 88 was chosen there. Incorporating the knowledge from the similar cohort, a similar prototype study, they found that standard deviation to optimal have a standard deviation of systolic BP and diastolic BP of even 10 millimeter change. They incorporated to keep the type 1 error as 25. Nearly 66% is a number of 66 patients sufficient to conduct a study. To the dropout of 25, they incorporate 88%. 88 subjects can be needed for this study. So the number of people incorporated is 88 mainly because of arriving the statistical analysis and the previous knowledge we had from the previous similar prototype study conductor. This is demographic which is mimics as what we see in day-to-day practice, 50-year-old male or female coming with high BMI or high waist ratio with uncontrolled diabetes. So primary equivalent is clearly told. The change in 24 BP monitoring with this fixed combination will phenomenally have statistical reduction of more than 15 millimeter of mercury in systolic BP and 10 millimeter mercury in diastolic BP. This research was obtained from ambulatory BP blood pressure monitoring. What happens with clinical BP monitoring, this also shows statistical significance. So even clinical BP monitoring has incorporated this fixed combination. There is a drastic fall of BP by 13 systolic and 7 diastolic BP parameters. And rate responders, many people are able to achieve the target BP of 130/80. When you go by ABPM, nearly 36 patients are able to achieve the BP control. In clinical BP, it comes around 10. So the drug is safe, the efficacy has been proved. The people on this combination had able to achieve good, large number of people are able to achieve the target rate. So when you analyze the amount, the number of recordings for 8 weeks is 4168. Out of 4168 recordings, nearly 32 recordings were within the heart rate of 70